Welcome to the Brain and Behavior Research Foundation monthly Meet the Scientists webinar. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host and moderator for today's webinar. Today, Dr. Karen Wagner, a distinguished member of our Scientific Council, will present a webinar entitled Depression in Children and Adolescents. The Brain and Behavior Research Foundation is dedicated to funding research around the world to identify the causes, improve treatments, and ultimately develop cures for mental illness. The foundation has awarded close to $300 million in NARSAD research grants over 25 years. I'm delighted to introduce Dr. Karen Wagner. Dr. Wagner is the Marie B. Gale Professor and Vice Chair of the Department of Psychiatry and Behavioral Sciences at the University of Texas Medical Branch in Galveston, and Director of the Division of Child and Adolescent Psychiatry. She is an internationally recognized expert and pioneer in the treatment of childhood mood disorders. Her work has led to the development of evidence-based therapies for children and adolescents with major depression and bipolar disorder. Dr. Wagner is the recipient of numerous awards and honors, including the Foundation's 2012 Colvin Prize for Outstanding Achievement in Mood Disorders Research. She's been an active member of the Brain and Behavior Research Foundation Scientific Council since 2007. This will be an interactive event. We'll begin with Dr. Wagner's presentation, followed by a question and answer period. To submit your questions, please use the Questions tab of the webinar control panel. You can also submit your questions throughout the presentation. As your moderator, I will present your questions to Dr. Wagner, and we will address as many of them as possible. And now, I'm pleased to present Dr. Karen Wagner. Karen.
Thank you very much for that introduction. It's a pleasure to be here today and to discuss the topic of depression in children and adolescents. And what I'll be talking about during this presentation are the symptoms of depression, the course of depression, and what we know about current treatments for depression in children and adolescents. In terms of disclosures, I've received honoraria for presentations and have served as a consultant with no financial compensation for pharmaceutical company. Disclosures are listed in the slide. And most of the medications that I'll be discussing in this presentation are off-label for the treatment of major depression in children and adolescents, with the exception of fluoxetine and escitalopram. And that'll become more important as the presentation unfolds. So how common is depression in youth? There's recently been a study. It was the National Comorbidities Survey, and this was a face-to-face study of around 10,000 adolescents. And they were given a diagnostic interview to determine, what diagnosis they had. And when looking at depression, major depression or dysthymia, the findings, and this is fairly recent, the findings are what we might expect in terms of male-female gender ratio, with more females, almost twice as many females, reporting symptoms of major depression or dysthymia. And then you can see that as age progresses, that the prevalence of depression increases over time. And if we were to look at overall the total in terms of lifetime prevalence of adolescent depression, about 11–12%. And of those adolescents, nearly 9% reported that they had severe impairment. Well, how do we make the diagnosis of depression in children and adolescents? We use the same criteria that we use for adults, same criteria in children and adolescents. So now we have diagnostic criteria, but what I think is really important for clinicians and also for parents of children or adolescents, parents who might be concerned that their child has a mood disorder, what do these symptoms look like in youth? So if we take the first one, obviously to have a diagnosis of major depression, a child has to have a mood disorder. And so what is that mood? The mood can present as depressed or irritable. Depression reflected in sadness, that's one that can be readily identified. It's the irritability that often can be missed. And where you can often see irritability in depression is for teenagers. They may be just irritable about everything. Everything annoys them. Everything, from school, they complain about teachers at school. They complain about peers. They complain about their family. They complain about siblings. And it's a degree of irritability that goes above and beyond what you might see in typical adolescence. They may not appear sad, and so that's where it can get missed, but their mood state is extremely irritable. And then there are accompanying symptoms of that, and in order to make the diagnosis of depression, there need to be 5 symptoms. So a depressed or irritable mood may be one, or the other is diminished interest in activities. So these are children or teenagers who just don't want to be around friends anymore, who may start dropping out of activities, not being in sports, dropping, band, gymnastics, not wanting to be in any after-school activities. Parents will often say that their child or teenager spend a lot of time in their room by themselves, and it's not as though they're in their room interacting with other children online. They just tend to spend less and less time with peers and with family. And then there can be associated appetite changes, either an increase in weight or a decrease in weight. And then sleep disturbance is another feature of depression in this age group, often difficulty falling asleep at night and waking up in the middle of the night. And then sometimes you can see youth who are, appear to be slowed down or a little bit more revved up. That's not as quite a common symptom that you might see with children as much as you do with adults. Another symptom of depression can be fatigue or loss of energy. And in this case, you can have children or adolescents who come home from school and they take naps. And that's really unusual to want to spend a lot of time sleeping for youth, and you can see that sometimes with depression. And then there's the feeling of worthlessness, guilt, low self-esteem. And these are teenagers who we often feel there's like nothing good about themselves, that other people don't like them. They, if they're attractive, they find themselves unattractive. They feel that they're just not as good as other people. The diminished concentration, that can be reflected in declining school grades. So, and with the declining school grades, it's often a slow transition down, where you have a student that may have started as an A student and then they're a little more B's, and next thing there are C's coming in. And that, in the constellation of all of the other symptoms, may be indicative of the impaired concentration that occurs with depression. And then an important and very concerning symptom of depression in youth is suicidality. Thinking about suicide, attempting suicide, having plans for suicide. And this can occur in any age range. It can be young children on up to teenagers. You know, with young children, sometimes they take more vitamins that Flintstone or other vitamins that they think may kill themselves. The act may not do it, but it's really what you're looking at then in that particular case is intent. So we always assess for suicidality in children and adolescents who have depression to determine appropriate treatment and to be concerned about safety issues. Now, another factor with depression is that depression may have other disorders associated with it. And why it's really important to identify those disorders is that these comorbid disorders affect not only the course of the disorder, but they also have implications for treatment because the treatment may be different. You can spend a lot of time treating a depressed child, and if they don't seem to be getting well, one of the factors may be that there are comorbid disorders that aren't being treated that are worsening the depression. So it's critical early on for there to be a thorough diagnostic evaluation if there is any concern about a child's mood, particularly if there's concern that the child is depressed. So what are some of those comorbid disorders? Anxiety disorders, ranging from generalized anxiety to social anxiety, obsessive-compulsive disorder. Another commonly occurring comorbid disorder is attention deficit hyperactivity disorder. And that's an important one to treat because children that have attention deficit hyperactivity disorder often aren't doing well in school because they can't pay attention or are very hyperactive and they have behavioral problems in school and difficulties with peers. And if that's not addressed, then a child who already has depression may even have lower self-esteem, may even feel worse about themselves because they're failing in school because they can't pay attention, and they're getting in trouble in school because they can't sit still. So each thing can get magnified if each disorder that a child has is not adequately treated. Then conduct disorder, where a teenager may have problems getting into trouble with the law, can be associated with depression. Substance abuse is another disorder to look for, especially in untreated depression in youth. And then eating disorders need to be evaluated for children who have depression. Well, how long does an episode of depression last in children? To make a diagnosis of depression, if we look at the Diagnostic and Statistical Manual, it says symptoms must be present for 2 weeks. Now, that is the bare minimum. And for many of the children that have depression, they have had this disorder for a long time before they come in for treatment. And the mean course of an episode of depression is about 17 months, about a year and a half. Now, that's a really long time to be depressed, especially in the life of a child. There is so much cognitive development, social development, emotional development that needs to take place, that to be depressed for that period of time can really have significant impact on a child. It's basically being depressed for at least a whole school year. And that's a lot to miss if a child is depressed, withdrawn, not interacting with peers. So it's important for us to identify this disorder as quickly as possible, but thoroughly as possible, and then to prescribe appropriate treatment for the child. Now, if a child has depression, teenager has depression, do they get well? Yes, they do. And recovery rates over, at least in studies that have been done over 5 years, are that the majority of youth do get better in that period of time. from an episode of depression. But a thing that's very important, though, is that the depression can recur. And about 40%, so less than half, will have another episode of depression. So it's important after a child is treated to watch for symptoms and to inform a parent that it is possible that the symptoms will reoccur, to educate everyone about what the symptoms of depression are, to remind everyone, and to watch very carefully if they should start to recur so the child can be brought back in for new assessment and have treatment given if indicated. Now, other effects of depression, early onset. I mean, depression is a very serious illness no matter what age it occurs. But there's increasing evidence that the earlier the onset of depression, the more adverse effects it can have in life later on. And this was an interesting study looking at the effects of early onset depression and suicidality. And what you can see is with the, just get back here, with the individuals in the study, they were all adults by the time the study was done. But in the left-hand column, this is those individuals who had the onset of their depression before the age of 18 compared to those who had the onset of their depression in adulthood. And what you can see is that if you look at the number of suicide attempts, significantly more suicide attempts in those that had depression at 18 compared to those that had their before 18 compared to those that had it after 18. And if you look at the duration of depression, much longer time being depressed for those that have had depression early onset compared to those that had adult onset, and the number of depressive episodes also were more in the group that had early onset compared to those with adulthood. And then if we look at substance abuse, are youth that have depression at increased risk for substance abuse compared to those youth that don't have depression? And this was a study comparing twins, 1,500 twins, and they were assessed at age 14 and at age 17. And those that had early onset depression, so at age 14 had depression, they were much more likely, more than twice likely, to smoke cigarettes, to 4 to 5 times more likely to use drugs frequently, twice as likely to use alcohol frequently, and then more episodes of intoxication. So this is just another example of how depression early on can affect long-term outcome for many things, ranging from suicidality to substance abuse. Now, what about adults, and children? What is the continuity between depression in children and adolescents and in adulthood? That is, are children or adolescents who have depression likely to be adults who have depression? Or is it a disorder that's limited, that you have your episode in childhood or adolescence and then there is no relationship in adulthood? Which way does that go? Our evidence is that there is continuity between depression in youth and having depression in adulthood. And this was one study that looked at 113 youths that had major depression, and they were followed up into early adulthood. And of those, more than half had a subsequent episode of depression in adulthood. And nearly 20% had remained persistently depressed since adolescence. So a disorder that has chronicity, a disorder that can go on into adulthood. So given all of that, given how serious this disorder is in youth, what do we know about the treatments of this disorder, and how effective are our current treatments for this disorder. Well, if you look at this slide, these are the FDA-approved medications for major depressive disorder. And as you can see, that list is not long. If this were a presentation on FDA-approved medications for adults, this would be a very extensive slide. But currently, we have 2 FDA-approved medications: fluoxetine from age 8 to 17, and escitalopram, ages 12 to 17. Now, when we think of FDA approval, basically FDA, what ends up with FDA approval is that there's usually 2 positive studies, 2 studies in controlled settings, double-blind, placebo-controlled settings, that have shown that medication is superior to placebo. And that in general, leads to FDA approval. So if we look at this, we can see from this slide on FDA approval that we have no medications below the age of 8 for which there is FDA approval. And in large part, that is due to that there hasn't been studies. There just really haven't been. Most of the studies don't start until age 8. And so we don't have data on how effective are these medications in young children. And then another thing to note here is that we only have one FDA-approved medication for someone who is younger than 12, and that's fluoxetine. There have been 3 positive studies of fluoxetine, but that's the only one. For teenagers, you can see that there are 2 FDA-approved medications. But the situation is this. There are some children that, say some 9-year-old, they may not respond to fluoxetine. They may, either it may not work, or it's possible they had a side effect and it wasn't an appropriate medication for them. Then we have to say, well, if we are going to treat with medication, what would be a reasonable next step? And that's where, for clinicians, it's important to know what the data is. It's important to know what's been studied and what hasn't been studied, and to try and use medications that have been studied and have shown to be safe, and then also that have shown to have some efficacy. Those are the ones that obviously should be used first before using medications that have never been studied in children. So what has been studied, and where do we have some positive studies where the medication was superior to placebo? If we look above that red line, there has been a positive study of citalopram in ages 7 to 17 with showing the medication was more effective than placebo. And for sertraline, there were 2 studies done. They were, before the study was designed, they were determined that the results of the 2 individual studies would be pooled, and that would be the analysis. And on the basis of that, it was a positive study. If we look below the red line, we can see that there have been a number of other studies of other medications where the medication was not superior to placebo. Response rates in the medications were about 50 to 60%, and response rates for the placebo was about 50%, and therefore there wasn't a difference. But going down those, you can see that something like mirtazapine, nifazodone, venlafaxine, those are non-selective serotonin reuptake inhibitor medications. Those just at this point haven't demonstrated efficacy in our controlled trials. But the others, the selective serotonin reuptake inhibitors, things like citalopram, fluoxetine, escitalopram for adolescents, have. So overall, if we look at that, we need to know for both our medications and our psychotherapies, how effective are they in treating this disorder? It enables parents to know what to expect, and it also helps to guide the future of treatments. What more do we have to be thinking about? Where should the field be going in terms of treatments? So if we look at antidepressants, the response rate for an antidepressant is about 60%. So in general, you can get about 60% of children will respond to the first antidepressant that they're given. And I mean, that's a good thing. That's more than half. When treated with an antidepressant, will have a good response to the medication. Then, if we're at that point, we have to say, well, what else could be done? If they had that antidepressant, how many more children could get well? Can our response rates increase if we add psychotherapy? If someone were to be started on medication and then you were going to say, gee, I want to have psychotherapy added to that. That is an important issue to address, which I'll do in 1 minute. But before that, I just wanted to mention that in terms of who are the people, who are the individuals, the children that don't respond as well, that don't have that response to that first antidepressant, it's if they have more severe depression, if they're suicidal to start with, if they have a lot of comorbid disorders, if they're hopeless, and if there is a lot of family conflict. Those are the children, when they come into a practicing clinician's office, the clinician may want to think, I'm going to try that first antidepressant, but they have a lot of these risk factors for not quite doing as well as a child that doesn't have those characteristics. So the other issue with that, too, is are there other characteristics that may make a child not respond as well to treatment? And here is one that's received a lot of attention recently and is very important. This has to do with the effects of depression in a parent. If a parent is depressed, does it affect their child's depression? And there is, again, increasing evidence that it does. And if we look at this particular study that was done, the red is at baseline. And we can see here that these are mothers who had depression, and it was whether the mother got well when they were treated. And so on the left over here are mothers who had depression and they were treated. And on the right are mothers who had depression and they didn't get well. And what you can see is that the children of mothers who got treatment, their depression went down when the mother got well. So it went straight down. But look over here. The mothers who were depressed, who didn't get well when they were treated, their children's depression went up. And you can also look at this. This is really interesting, the way the curves go together. This is whether if a parent is depressed. When a parent's depression is high and it goes low and they get better, look down below. The child's depression follows very close to that curve. So if a child has depression and if you're a clinician treating them or and they're not getting well, it's really important to think, is there someone at home, is there a parent who's depressed who just hasn't been treated? And that it's important that the parent get treatment so that it can help with the course of their child's depression. That can help improve their child's depression. It's a lot of demands for a parent to take care of a depressed child. It requires a lot of resources for a parent, emotional and otherwise. So it's really important that the parent's depression be treated, given the interaction between the parent and the child depression. the other issue that's often raised with treating that child, say that the 60% of children that get well, how long should they stay on that antidepressant? So they start an antidepressant and they're better. What would be a reasonable period of time to stay on that antidepressant? There is one study that's been done that is very useful in providing at least preliminary information on this. If you look at this study, this just happened to be a study of sertraline. So antidepressant medication was given for 12 weeks, so we'd say that's 3 months. And anybody who responded got to continue on this sertraline for 24 weeks. So at this point, they have now been on the antidepressant for 9 months. Is that long enough? So the study was designed then to put half of them continue on sertraline and then give the other half placebo, a sugar pill, and see what happens. Well, what happened was that after being on sertraline for 9 months, if they went on placebo, nobody continued to do well. Everybody had a relapse. All of those teenagers, depression came back. For those that stayed on medication, about roughly 40% continued to do well. So if we look at this, we can say that 9 months is too short for staying on an antidepressant, that longer may be better to decrease the likelihood of a relapse. So what do we say clinically? What would be, a reasonable thing to think about? Staying on medication for at least a year after getting well. Now, it may take about 3 months to get well. So if you add a year to that, you could be talking about maybe a year and a half on medication and then a slow taper of the medication. Not lifetime medication treatment, but not so short. Under a year is probably too short to maintain response. So maybe about a year and a half on the medication. Okay, so getting back now. If you have 60% of youth that respond to an antidepressant, what about if you add therapy? And the therapy that's been most studied for adolescent depression is cognitive behavior therapy, trying to change the way a child thinks, to try and change a lot of these depressive thoughts they have, and to learn skills that can help to improve their depression, change their behaviors. So this is the treatment of adolescent depression study, and it was designed to see whether fluoxetine medication or medication and therapy, or therapy alone, or placebo, was the best treatment over a 12-week period, 3-month period of time. So what you can see is that given medication and therapy, about 70-ish% of adolescents got well. And if we look at medication alone, again, it's about 60%. So you can get about 10% more youth well by adding the therapy. And that's very good news. What it showed is in terms of therapy alone for adolescents who were moderate to severely depressed, it was not significantly better than placebo. So our findings are that if a child has moderate to severe depression, the most effective treatment is combination medication and therapy. Then if you were forced to pick between therapy or medication, the medication alone, and then therapy, not for moderate to severe to start, but look what happens over time. Therapy catches up to the other treatments. So the issue really is there time to wait for the therapy to work? If a child is severely or moderate to severely depressed with suicidality, you really want to be thinking about combination treatment and not waiting time for this efficacy of therapy. Now, what happens if you start one medication and it doesn't work? Child is tried, let's say, on fluoxetine, and a selective serotonin reuptake inhibitor, and they don't respond to it. Well, the clinician's faced with, should they stay in that same class of medication or go to a different class of medication? Or if they had just been on only an antidepressant alone, should they add, again, the cognitive behavior therapy? So the treatment of SSRI-resistant depression in adolescent study asked and answered that question. This was a very large study of adolescents, and they were given either another SSRI, a different one within that class. The CBT was added in another group, or they were switched to venlafaxine as an example of a different class of medication. And the findings were that it didn't matter whether they stayed on went on a different SSRI or a different class of medication. Roughly, response rates were about 50%. Why is that important? This is important because what it says is this. If a teenager doesn't respond to the first antidepressant, they have a 50% chance of responding to another one. So that's really good news. It's not hopeless that because one antidepressant didn't work. About 50% of teens will respond to a different antidepressant. Very good news. What about the psychotherapy? Again, you see, if you add psychotherapy, roughly 10% more will increase the response rate by about 10%. So adding psychotherapy is important when using medication. So what is our treatment? How do we usually, if we're using medications, we start with, usually, in general, it would be an FDA-approved medication in that age group, and that's one of the SSRIs. If they don't respond to that, we tend to go to another SSRI because although something like venlafaxine was effective, if given, it had more side effects. So we tend to stay with ones that have less side effects. So we do those two, and if that doesn't work, we might go on to a different class of antidepressant. An important thing, these are just some listings of our antidepressants. With children, it's usually best to start at doses lower than like half of what the adolescent has. I tend to cut the doses in half for children, starting doses, so that they don't get side effects, sedation, feel agitated, feel jittery. Start lower, but ultimately the doses tend to go to, if you need to, the upper end. But start lower in young children. What about omega-3s? People often ask about that, the role of some of these alternative treatments. This is a very small study, 28 children, and they were given either omega-3 or placebo. And the findings in the study were that 70% of these youths responded to omega-3, and none in the placebo group did. I mean, that's unusual. Normally, placebo response rates are about 50%. So this has some, there's some preliminary optimism with this, but it really needs to be studied in, a very large sample, just like the antidepressant trials, to see if this holds when done in a larger sample. But it's something worthwhile to look at. What about exercise? People always say, is exercise useful for depression? This was just reported, and again, it's very small, 13 adolescents. They were depressed, and to be in this study, they had to have low level of physical activity. And they were given supervised exercise sessions, some independent sessions, and one of the outcomes was that everybody stuck to the protocol, and that's a good thing. But I want to add that the gym was located where the people got their treatment, so it made it easy. But that was good that they completed it. And there was a significant decrease in depression. But again, a small sample. It's not a controlled study or anything like that. But it's something that may be worthwhile to add on to a typical regimen for depression, standard treatment, therapy, medication, and increase exercise. Now, just a little bit of a switch. I wanted to say some about this issue of concerns about antidepressants and suicide risk. We know we have the box warning on that, and all and parents should be, and teenagers should be apprised of the box warning about there being an association with antidepressants and increased risk for suicidality. After the box warning came out, there have been more studies looking at it, and this one was interesting. Seeing these were 18-year-olds who had received antidepressants, and if you look, the time of greatest risk for suicide attempts was the month before being treated, and then if you notice, the risk went down. And then for the next one, this was interesting. In the treatment of adolescent depression study, they looked after the study was completed to see what predicted those adolescents in the study that either had suicidal thoughts or attempted suicide. There were no completed suicides, but for those that that during the course of treatment thought about suicide or attempted suicide, and there was, if they had higher suicidality when it started, if they had minimal improvement in depression or moderately depressed, but interestingly, 3/4, 75% of the cases, roughly 75% that had suicidal thoughts or attempts were those that had an acute interpersonal conflict. What does that mean? What that means is that they had a conflict with a peer or with a parent. And so what I recommend to parents when I'm treating depressed children, try and keep the conflict as low as possible during those early stages of treatment, because those are the kinds of things that can lead to a precipitous, not thought through precipitous suicide attempt or suicidal thinking. As best as possible, keep conflict low until the treatment has been set, and then start dealing with whatever in a constructive way, whatever issues need to be dealt with. So in summary, then, depression in children and adolescents is a serious serious illness, and one that has effects during childhood, can go on into adulthood. It's important that we have efficacious treatments for this disorder. To date, the most effective treatment is combination of antidepressant medication and cognitive behavior therapy for treatment of this disorder. So I want to thank you very much for the opportunity to talk with you today, and we'll turn the conversation over to Dr. Bernstein.
Thank you so much, Dr. Wagner. That was an excellent presentation. You have a way of taking what could be somewhat complicated issues and putting it in a way that's very accessible to people. So
thank you.
Thank you. We have a number of questions, and one of the questions relates to a little bit more about for parents, how to differentiate between what we might view as typical teenage issues versus really potentially having a depression. So I wanted to ask if you could give a little bit more information about that.
Yeah, I mean, that's really an important question, and I think something that it's difficult for everybody to determine what's normal mood in adolescence versus when is it depression. And what I tend to look at is duration of symptoms and in particularly impairment. I mean, if a child, say a teenager is irritable, is that irritability affecting their school grades? Is that irritability severely affecting the quality of family life for an extended period? Not just, a few weeks where the teenager's irritable and things aren't going right in their life. It's really when you start to have impairment, when they start having declining school grades, when they start having either losing some friends, starting to lose friends, or having a real shift in a peer group in a non-positive way, moving into a group that a parent really sees as a problem. And when they start spending increasingly time alone and their peers are not. Because sometimes you can have teens in their house all the time, but they're interacting with peers in another house. They're just doing it online. But when they become more isolated, that's another when the irritability has gone on too much. And it's usually a progression. This just doesn't happen overnight. And what I recommend to parents is just take a step back and say, where was my child 2 years ago? How was their life going 2 years ago? Did they have friends? Were they doing okay in school? Were they getting along with the family? And how about last year? And then how about this year? How much has it changed? And if you start adding that up, grades going down, friends changed, no particular interest, really isolated, very irritable, and it's really different than the other time and not just a little short period of time, then I'd say it's worth it to go in, have them have an evaluation. If anything for the parent, it will either give them relief, peace of mind, or it will say, their judgment was their concern was right and that they really should be concerned. And if there's any talk of wishing they were dead, above and beyond that you say, you can't go out tonight, and the child says, I wish I was dead, and that's just something they said off the top of their head. Any serious statements about suicidality, that has to be assessed.
And I want to talk a little bit about the suicidality issue in a moment, but I just want to get back to, let's say there is a circumstance where the parent steps back and has a concern. What advice do you give parents in terms of telling their child that they're bringing them in for an assessment? Because I think often parents are a little anxious about now, how do you tell your child, let's go see a psychiatrist for an evaluation?
Well, I think, I think they say the child's teenager's irritable, and I think a parent really, it's best, especially with teenagers, to just be straightforward with them and say, to say that they're concerned. And they may say something like, I know you're not concerned about this, because a lot of times the teenager isn't. I know you're not concerned about this, but I really am concerned. I'm just concerned about your mood. I know you don't think it's a big deal, but it's really a big deal. It's affecting the family. I'm worried it might be affecting your school grades. I know you don't think so, but as your parent, it would be just like if you had some sort of medical illness, a really bad sore throats, stomach pains that never went away. I would bring you in for an evaluation, even if you didn't think that it was anything. I just need to do this to make sure that you're okay, and put it as that.
Okay, that's good guidance. And going back to the important issue of suicide and suicide prevention, there's no greater tragedy than, God forbid, losing a child to suicide. What if a child is depressed and getting treatment? What guidance do you give to the parents above and beyond, I think, the important guidance about minimum conflict? What other guidance do you give to the parents about how to minimize the risk of, God forbid, the child attempting suicide?
I think it's important to talk to the child or the teenager that they, they know they've seen whoever, whatever mental health provider's done the evaluation, but that they have that they have depression, and that sometimes when you have this kind of an illness, you can have thoughts about wanting to hurt yourself, and that what I encourage parents is to tell their child to tell them any time that they're thinking about those things, to keep open communication about it. Let it be something that's okay to say, and that we'll deal with it, and we'll talk to your psychiatrist or psychologist who's ever doing the treatment about this. It's keeping things open like that, and then keeping anything like if there are no guns in the home, things if people feel strongly they need to have guns in the home, there should be no ammunition in the home. I mean, something, keeping nothing in the house where someone could hurt themselves, weapons in particular. But even if you're concerned early on, and you're not worried, just keep the medicine out, something that would be easy for someone to take, get that out of the way. But I really encourage open communication with the teenagers. Let them know that you may have these thoughts. It's really important. We want to know about these.
But that's very helpful, and obviously a part of therapy is to encourage the family to have more open communication, which is hard for parents and teenagers. So I think that's very good advice. Another challenging issue, whether or not depression is present, is the issue of alcohol use and abuse and other drug use and abuse. And one of the questions that someone brought up is almost a chicken and egg. Does the drug abuse cause the depression where there's concurrent diagnoses, or does the depression encourage the drug abuse? I want to ask you to address that issue.
Yeah, that's another important issue. I mean, when I see someone that has both, what I try and do is to do a really good history and see which preceded which. And that really requires spending time with the teen and spending time with the parent. So they may have had depression, may have started with depression, and it was unrecognized and untreated, or the treatment wasn't effective. But say they hadn't been treated. So you have that, and you may assume then that depression is still underlying that, and treatment would be important. But the substance abuse now complicates the depression treatment, because using substances can, in and of themselves, produce depression, so they need treatment for the substance abuse. I find it extremely difficult to treat depressed children who are abusing substances without having substance abuse treatment. So if they're depressed, say not suicidal, but using substances, I strongly encourage the parent to get them into a substance abuse treatment program. That what we can do antidepressant-wise and therapy-wise is minimal while there's ongoing substance abuse. So that has to be addressed.
Okay, very obviously important issues. You spoke about the significant percentage of people who respond, teenagers, youngsters who respond to treatment, which is the good news, and the percentage of people that, if they don't respond to the first line of treatment, will respond to the second, and the issue of adding on talk therapy. What do we do for somebody who really doesn't respond, that smaller percent that isn't having a response? What should be done to help those people?
Yeah, so that might be a smaller percentage, maybe 20 by the time you switch medications and add. In those cases, what we tend to do is systematically try other medications and add, have combination treatments. So sometimes added to an antidepressant, lithium may be added to an antidepressant, or an atypical antipsychotic may be added to an antidepressant, and that can pick up another good percentage of individuals who respond. And then there can be changes in the therapy. Just because cognitive behavior therapy has probably been the most studied, there are alternative therapies. Family therapy, may be necessary to think about something like family therapy, or having the teenager participate in some type of a group if they're dealing with a specific issue. So it would be changing medication, or combinations of medications, or altering the therapy would be things that I would try in those cases that are truly treatment resistant to standard, typical early on treatment.
Okay, that's very, very helpful. In addition to minimizing conflict, are there other steps that families should take, parents should take to reduce the stress on a teenager while they're initiating and having ongoing treatment?
Yeah, I think that when it's recognized that they're depressed and say they're not doing well in school, initially that would be an example of initially when they're being treated to let the grades be the way they are, to not have a lot of expectations. It's not have to do with conflict, but a lot of expectations right at that period. What I say to parents would be like, if your child was just diagnosed with mononucleosis, you're not going to say to them now, you have to have like all A's or all B's, and I expect you to participate in this, and just to try and lighten up a little bit on the expectations and demands early on until we can get this treatment to start take a hold for your child. So it's not conflict, it's just reducing stress at home.
I think that's an important point and a good example to, I think people are more readily, the idea of reducing added stress in a child, an adolescent who has mono comes natural, and I think you're pointing out the importance of doing that in somebody who has a depression should come just as natural to parents.
Exactly.
Well, Karen, I want to say thank you so much for an outstanding presentation. Your work with children is especially inspiring in that it opens up the possibility that early intervention for these illnesses obviously make a big difference in people's lives. And catching a psychiatric condition early increases the chance for the person to lead full, productive, and happy lives. And I want to thank you for all of the research that you do, and certainly for the time that you spent with us today.
Thank you, Brian.
Yeah, no, thank you. And in addition, I want to thank our audience for joining us today. The Foundation, through its research grants, is dedicated to improving the lives of people with psychiatric conditions. And I thank our constituents for joining us in that mission. All of the research we fund is made possible through private donations. So if you'd like to consider making a gift, please visit bbrfoundation.org or call our 800 number, 1-800-829-8289. This webinar has been recorded, so if you missed any portion of the presentation or would like to share it with a family member or friend, please visit our webinar page on our website. I hope that you'll join us again next month when we'll hear from Dr. Dennis Charney of the Mount Sinai School of Medicine. Dr. Charney will speak to us about resilience, the science of mastering life's greatest challenges, and that will take place on Tuesday, July 9th at 2 p.m. Once again, thank you all for joining us, and again, thank you, Karen, for your extraordinary presentation.